The objectives for today are, again, to review the updated FIGO staging, and then to review the recent literature and new recommendations regarding surgical management of early cervical cancer. So to understand the previous staging system, it's important to understand that cervical cancer is largely a global disease. So even though there are over 550,000 new cases every year, 85% of these are in developing nations. So as you can see, a lot of the incidence and mortality of cervical cancer occurs in resource-poor environments. So cervical cancer staging previously was clinically based, which was easy to apply in resource-poor environments. So it was based upon physical exam, X-ray, cystoscopy, and proctoscopy was allowed, but CT, PET scan, or surgical findings were excluded. So if you had a positive lymph node on your imaging, you can include that in your staging information. In the last decade or so, even resource-poor areas have adopted ways to assess lymph node status, which led to FIGO updating their staging. So just briefly to run through the changes, stage 1A removed all information regarding horizontal spread. And stage 1B removed information about clinically visible lesions. I believe the 1A in this change is just due to the fact that if you're looking at a cervix, it's difficult to assess the dysplasia or precancerous changes from microinvasive disease. They also added a 1B3 category with new size criteria. The less than 2 centimeter is consideration. You could possibly perform a trachelectomy or just removal of the cervix. Less than 4 centimeters is usually the cutoff where you would consider them potentially a candidate for a radical hysterectomy. Greater than 4 centimeters, we usually refer for radiation therapy. There were no changes to stage 2. And stage 3 is where they included the information for now lymph node involvement. I really like this change. It's really simplified communication between providers. So now if I see somebody with a 2 centimeter cervical lesion, but they have a positive pelvic lymph node on PET scan, I can say they're a stage 3C1 as opposed to this is a stage 1B2, but she has a positive pelvic lymph node. There were no changes to stage 4. A good staging system should be able to differentiate the anatomic extent of disease and provide survival information for patients. So now by allowing us to include lymph node status, I think the staging system hopefully will do a better job of those things. In addition, I like it because it now provides better guidance for ordering imaging studies when these patients first come to you in clinic. And then, like I said, it simplifies communication between providers. The stage now, if they're a 3C, that implies the same information as why I'm referring these patients for radiation treatments, as opposed to me having to explicitly state, you know, this is not a candidate for a radical hysterectomy due to positive lymph node. Which leads me to the changes in surgical management. So early stage cervical cancer can be treated surgically alone. For the very early stage 1A1s without LVSI, they can be managed by a cone or just the traditional extrafascial hysterectomy. If they're a stage 1A1 with LVSI, 1A2, 1B1, or 1B2, we could consider them candidates for radical hysterectomy if we believe that by the surgery alone, they will not need any adjuvant radiation therapy. A radical hysterectomy differs from a traditional hysterectomy in the fact that in addition to removing the uterus and cervix, we also remove the upper portion of the vagina, the perimetria, which is the tissue on either side of the uterus, to the pelvic sidewall and the pelvic lymph nodes. This is a much more complicated procedure, longer OR time, increased risk of blood loss, increased risk of complications. It was traditionally performed through an abdominal approach. And then as we became proficient at minimally invasive methods, we adapted this procedure to be performed either laparoscopically or robotically. This was not really very well studied when we initially adopted this approach, but a few retrospective or single institution studies led us to believe there were similar outcomes. Then came the laparoscopic approach for cervical cancer trial. This was initially presented at our annual meeting in 2018. The primary objective was to compare disease-free survival at 4.5 years between patients who had undergone a minimally invasive radical hysterectomy, so that could be laparoscopic or robotic, versus an open traditional abdominal radical hysterectomy for early stage cervical cancer. Some other of the secondary objectives were patterns of recurrence and overall survival. This was an international randomized trial with 33 centers that looked at either MIS versus open radical hysterectomies. It was based to be a non-inferiority design, so stating that MIS was within 7.2% disease-free survival of the laparotomy or open radical hysterectomy group. This was based on a 97.5% one-sided confidence interval with 90% power. The inclusion criteria were squamous cell carcinoma, adenocarcinoma, or adenosquamous of the cervix, stage 1A1 with LVSI 1A2 or 1B1. So this was the old staging system, so all tumors less than 4 centimeters. In order to participate in this trial as a site, the management committee had to review your last 10 MIS cases as a surgeon. So your last 10 radical MIS cases, they looked at your operating room time, your blood loss, your length of stay, and any complications. If you wish to participate in this trial as a surgeon, you had to have the ability to be able to perform the procedure both through open and minimally invasive methods. And you also had to submit 2 completely unedited full-length videos of you performing a radical hysterectomy with MIS methods. Ultimately, this trial was stopped early by the Data Safety Monitoring Committee. So just to review some of the characteristics, the TARH group is the open group. The TLRH, TRRH is the laparoscopic or minimally invasive robotic group. They were well matched in age, BMI, stage of disease. Both their OR times and median length of stay, there was no difference. Looking at the histopathology, there was no statistically significant differences in cell type or grade. The only statistically significant difference between the 2 groups was that the minimally invasive group had more tumors that were superficially invasive, so that should have benefited that group. They were well matched in tumor size, LVSI, parametria, positivity, and positive vaginal margins. They had the same number of lymph nodes removed, same rate of lymph node positive. So this is looking at the primary outcome, the disease-free survival. So this side favors the MIS group, and this side favors the open abdominal group. This is 0, and this is their non-inferiority boundary of 7.2%. So you can see both the intention to treat and the protocol group, looking at disease-free survival at 4.5 years, was below the non-inferiority boundary. So it favored the open group. And then looking at the Kaplan-Meier curves for disease-free survival, progression-free survival, disease-specific survival, and overall survival. The green line is the open group and the blue lines are the minimally invasive group. And you can see that all 4 were statistically significant and favored the open radical group. So then also looking at local regional recurrences, the MIS group had more local regional recurrences than the open group did. So ultimately, the MIS radical hysterectomy was unable to be declared non-inferior to the abdominal radical hysterectomy due to worse overall survival and recurrence risk. So that study was, study was immediately followed by this study at the same meeting. MD Anderson performed a comparative effectiveness of minimally invasive staging surgery in women with early stage cervical cancer. So this was a national observational study looking at all-cause mortality between the MIS and open radical hysterectomy. This was looking at 1A2 and 1B1 cervical cancer patients. The primary analysis compared all-cause mortality looking at propensity scores between the years 2010 and 2013 using the National Cancer Database. The secondary analysis they performed was with an interrupted time series between the years 2000 and 2010. And this was using SEER database information to evaluate how adoption of MIS affected survival. 2006 was the year where MIS surgery was really starting to be increased for radical hysterectomies. And so this looked at the years immediately before and immediately after adoption. So looking at the results of their study, MIS resulted in a 48% higher hazard of death from any cause, and that confidence interval did not cross 1. So this pink group is the MIS group and the blue group is the open group. Then looking at the adjusted probability of death, both at 4 and 5 years, was statistically significant to favor the open group. I thought that this part of their study was very interesting. This was their secondary analysis using the SEER data. So they looked at 4-year relative survival each year. And so these little dots are the proportion of the radical hysterectomies performed with minimally invasive surgery. So 2006 was the year where they really, the proportion increased. So you can see it in the years leading up to 2006, there's a non-significant but trend towards improved survival each year. Then after 2006, there was a statistically significant change with a decrease of 1% survival per year. The argument they also discussed during this presentation was that if we were performing the same, what we think is the same procedure with minimally invasive methods, because we think that it leads to better outcomes for our patients with postoperative complications and morbidity, not only should we expect to see at least the line continue, but we should actually expect to see the slope to increase, and instead it went down. So after this meeting, both of these studies were published in the New England Journal of Medicine, and the FDA released a statement of caution regarding robotic surgery. GYN oncologists did not like the results of this trial. We believe we were performing the same procedure, and so we didn't understand why robotics or laparoscopic would change the outcomes. So there were a lot of people trying to figure out, why did this trial have these results, and is there something we could have changed, or is there some problem with the trial? So some of the criticisms were, did the individual sites have enough proficiency at minimally invasive surgery, but they had to submit full-length videos, so arguably they should have. And then 85% of the minimally invasive procedures for this trial were straight stick laparoscopy. And so some people wondered, would the results have been different if it were performed in a setting where mainly these surgeries were performed with robotics, like the United States? But again, they had to submit full-length videos showing that they were performing an adequate radical hysterectomy. And then also those countries see a lot more cervical cancer too. So they're, the number of times they perform this procedure is more than we do in the United States. Some people didn't like that the confidence interval crossed the non-inferiority boundary of 7.2%, but a non-inferiority trial's set up differently, so the confidence interval doesn't quite mean the same thing. Stopping the trial early affected the power, and then the recurrence rate was low in the open arm. And then for the second study, people didn't like that it was retrospective data. It was sequential comparisons. They were looking at overall survival instead of specific cancer outcomes, and the follow-up times were relatively short. Then if we do believe these results, why is this happening? Like I said, we think we're performing the same procedure. And so just the method of which we're performing this procedure, why is it affecting the outcome? So some theories are that the carbon dioxide gas that we use to insufflate the patient's abdomen is having an impact on tumor cell growth. To perform this procedure, we place a uterine manipulator in order to help us with visualization. So is some process with that uterine manipulation, is that allowing the tumor cells to spread? that maybe cervical cancer just inherently has a different oncologic behavior than endometrial cancer, which we perform robotic procedures for all the time. Or maybe we just aren't as good at MIS surgery as we all thought we were. So this was widely debated and discussed for an entire year. Many editorials were published trying to find fault with the LAC trial, which actually led to, at the next annual meeting, an entire special session regarding the LAC trial. So again, Dr. Ramirez got up, represented his information, and defended his trial from all of the editorials very eloquently. There were still, even after all of that, very many passionate believers in minimally invasive surgery, stating that they anecdotally aren't seeing the same information in their patients at their institution. A lot of people want a trial like this repeated, but then there's questioning the ethics of repeating such a large trial, and can you get IRB approval to randomize patients to an outcome or to a treatment group where the outcomes have been shown to be worse in a randomized controlled trial. Overall, the impression was that minimally invasive radical hysterectomies were being abandoned at most major academic centers. Interestingly enough, after these two studies were published, a lot of groups and countries went and looked at their own retrospective data and did appropriate studies, and actually time after time found the same information. So if you looked at minimally invasive groups, they had worse survival outcomes. If you looked at laparoscopic versus robotic versus open, the laparoscopic and the robotics had worse outcomes. So collectively, all of the studies suggested adverse oncologic outcomes for the MIS radicals, and it was published in this current opinion. So it changed the landscape of how we practice, really, for early cervical cancer. SGO released a statement saying that the contemporary literature suggests poorer survival outcomes, and that we should consider this when counseling our patients. Europe and NCCN even took it a step further, saying that the open approach is the gold standard. There are still many lingering questions and studies probably to be performed about this. What about lower risk cancers? For the stage 1A ones, as I said earlier, we just need to treat those with a routine extrafascial hysterectomy. Are those okay to be performed through minimally invasive methods? The tumors less than 2 centimeters don't carry the same recurrence risk, so is it okay to perform those with a minimally invasive radical hysterectomy? There are some subsets of the data that would suggest perhaps, but then it's probably not enough information. We're starting to perform some of our other surgeries through minimally invasive methods without looking further into survival outcomes. So do we need to study performing the same procedures before we really adopt minimally invasive surgery for all of our cancers? Then is there still a role for an MIS radical hysterectomy? It really does. To perform a good open radical hysterectomy, you need 2 qualified surgeons. And so if you're at an institution where you're a solo practitioner for GYN oncology, perhaps then considering an MIS radical where you can really sit at a robot and perform both sides of the procedure yourself. With increasing BMI, it becomes more and more challenging to see everything you need to see and to get adequate margins and a good lymphadenectomy. So in some of the obese patients, is there a role for an MIS procedure? Or what if you're practicing a place without good brachytherapy? Is there then a role, if you can only perform this procedure through MIS methods, would you consider a robotic radical for these patients? Or do we just increase our referrals to radiation oncology if we feel like we can't adequately perform the procedure for the patient? So it's was surprising trial results, and it has resulted in a lot of questions. Thank you.